Okay, everyone, hi. I'm Bertin. I'm one of your very nice critical care and friendly critical care fellows. So I used to do this. This would be like my third, fourth year doing this workshop. I usually used to do it in person, and I used to use the PCIM blogs as an opportunity to have everyone in person in the same lab so we could talk about this. But because there are some restrictions this year, and particularly because I'm a fellow, I no longer have time to do as many lectures as I was before. We're doing it this way. That being said, I'm going to try to do the first part a little bit more lecture-like, and the second part is going to be more case, where I hope that some of you are going to be able to participate and help me with the cases. I'm even going to have like a virtual simulator of a ventilator, so you guys can participate with that. So the first part is going to be just pure theory. If you have any questions, you feel free to unmute yourself and ask me. I'm going to try my best to answer them. I might miss messages on the chat, so if I miss any, just let me know. Okay, so the first thing we're going to talk about indications about mechanical ventilation, and this is a very broad, thing that you're going to be, and this is both for both invasive and non-invasive mechanical ventilation. You see all the time that patients are intubated, but sometimes we forget, why do we actually have to intubate them? The first one, I tried to summarize them in three large groups. The first one, which is improved gas exchange, and try to think of these patients that are severely hypoxic. You have them on BiPAP at 100% FiO2 and whatever IPAP and EPAP, and they're still hypoxic. Usually that patient needs to be intubated. And a similar note, you have patients that are extremely hypercapnic, and despite non-invasive mechanical ventilation, they still need to, add some assistance with their minute ventilation. Then those patients as well need to be intubated and initiated mechanical ventilation. The other one, which is a very interesting one, which is to relieve distress, respiratory distress. And I see this all the time with trainees and physicians that don't have as much experience dealing with respiratory failure, that whenever they have a patient that has respiratory failure, particularly when it comes to hypercapnic respiratory failure or increased work of breathing, they want to treat the gas instead of the patient. And you see that very commonly every time that there's a rapid and I go to the rapid, and the first thing I see is that the patient is breathing at 40, 50 breaths per minute using their accessory muscles. I think that at that point, that the patient needs to be intubated, but a lot of trainees still want a gas because they think, hey, if the gas looks normal, perhaps I can hold on intubating the patient. And that's never the case. Whenever you have someone that has amazing significant respiratory distress, that patient needs either some sort of non-invasive or invasive mechanical ventilation, but you need to support that increased work of breathing because that's leading to impending respiratory failure. And the last ones, which are very three important, that are absolute indications for invasive mechanical ventilation. If a patient is apneic, if the patient needs airway protection, for example, it has hematemesis or needs pulmonary toilet because of copious respiratory secretions, this patient needs to be intubated. Those are absolute indications for invasive mechanical ventilation. One of the things that all of you need to be very familiar with, because this is a very common issue you end up having with mechanical ventilation when you start it, is what are the hemodynamics effects of positive pressure ventilation. And the way I try to always explain it to everyone is take into account that the effects are different on the right heart and on the left heart. The left heart is the very easy one. Just think about how whenever someone comes with cardiogenic pulmonary edema and an acute decompensated heart failure, sometimes cardiologists, even if the patient is not looking that bad, they slap BiPAP onto that patient. And the reason for that is because when you do positive pressure ventilation for the left ventricle, the effect is that the preload decreases and the afterload decreases as well. So for anyone that likes cardiology, that should immediately make you think that that's heart failure management 101, right? So you do diuretics to decrease the preload and you do ACE inhibitors to decrease the afterload. So positive pressure ventilation is pretty much doing the exact same thing. Whereas with the right ventricle, it's a little bit different and a little bit more challenging. And that's why what you see is just a change in what the afterload does. So in the same manner, for the right ventricle, the preload decreases, but the afterload increases. And the way you have to think about it is that the positive pressure is squishing the pulmonary capillaries, which leads to an increase in the afterload for the right ventricle. And that's why you're gonna see that usually all of us in critical care are, whenever we have to intubate someone, we go ahead and intubate whoever needs it. But the only population we are always very fearful about intubating because we know they can crash very easily are patients with right ventricular heart failure and pulmonary hypertension. Because those patients already have a very weak heart, and what you're going to be doing the moment you slap a mechanical ventilator on them is that you're going to be increasing severely the afterload of a very weak right ventricle. Therefore, you're causing obstructive shock. To put it in a more graphic manner, just try to picture someone that has a weak right heart and now has a massive pulmonary embolism. Leads to obstructive shock, right? But if you do positive pressure in a patient with already a weak right heart, leads to obstructive shock as well. So that's a very difficult, very different scenario. So left ventricle, they love positive pressure. Right ventricle, they hate it. So always take into account that, because it's something you have to consider before initiating positive pressure in someone. Now, let's quickly talk about non-invasive mechanical ventilation. In general, this is positive pressure without intubation. And there are two types of modes in which you can do this, either continuous positive airway pressure, meaning Cpap, or bilevel positive airway pressure. The devices through which you can give non-invasive mechanical ventilation are very broad. For example, you can see nasal masks, nasal prongs, oral mask, and all of these are more likely used for OSA. Whereas the face masks that are for both nasal and oral covering, including the entire head mask, that's more used for bilevel positive pressure. One thing you have to take into account is what are the contraindications to using non-invasive ventilation. We already talked about the indications here, but like the contraindications are very important because it's always a problem whenever we go, they call us or a consult or someone with respiratory failure on the floor and we see BiPAP on someone that should not be having BiPAP. And for example, one that is very important is inability to protect their airway. For example, if someone has severe hepatic encephalopathy, lactic acidosis, the patient is pretty much comatose and the patient is deciding what you do is slap a BiPAP on the patient, you're harming that patient. That patient needs to be intubated because they cannot protect their airway. So you're just gonna make them aspirate. The same way, if you have someone with facial surgery or trauma, you cannot put non-invasive ventilation because you're gonna be harming their face. Severely impaired consciousness is a relative contraindication. And the reason for this is that, for example, if you have a patient with OSA, OHS that has acute on chronic hypercapnic respiratory failure, and they have altered mental status because of CO2 narcosis, it's possible that by giving them positive pressure and fixing some of that hypercapnia, their mental status might improve, and therefore you avoid an intubation. So that's why it's relative, because that's pretty much one of the few indications where you can do it. Another one is, for example, someone comes with a narcotic overdose. While you're giving them naloxone and you want the patient to wake up a little bit more, you do non-invasive. But in general, if someone is comatose or has a very severely impaired consciousness, they need to be intubated. Now, just to give you guys a broad, a simple explanation of what's the difference between Cpap and BiPAP, because I think this is very important for everyone to understand it. Look at these graphs, and more or less, this is like what our normal respiratory cycle would look with both inspiration and expiration, and these are pressure curves. When you add Cpap, the only thing that you're adding is expiratory support. You're adding no inspiratory support whatsoever, just exhalatory support. Whereas bilevel, the difference is that it adds both excellatory and inspiratory support. So to put it in broader terms, in more familiar terms, Cpap, it's pretty much the PEEP that you're providing to the patient, and in BiPAP language, it's the EPAP. Whereas IPAP is the pressure support or pressure control of the non-invasive ventilator. And in general, Cpap, we only use it for two reasons. One, when we have someone with OSA, or whenever we need to do airway stenting, meaning, for example, patients that have excessive dynamic airway collapse, they have tracheobronchiomalacia. This is an indication for using just Cpap. And the other one is BiPAP, that when we want to do that inspiratory support, meaning patients that have minute ventilation deficiencies, either because their tidal volume is too low or because their respiratory rate is too low. That's an indication for using BiPAP. Now, we're gonna talk very quickly about basic ventilator parameters, because for you guys as PGY1s, this is one of the main things I want you to be comfortable with, and you should all be comfortable with, which is what are the basic parameters that the ventilator has and you should be able to order. Because it happens every time, right? You're in the ICU, a new patient comes in and you have to put ventilator orders, or you have to put some sort of orders on the ventilator because nobody has told you what to do with this, particularly in non-medical units. So this is going to give you an idea of more or less how you have to set the ventilator. And the basic 4 parameters the ventilator has, regardless of the mode of ventilation, are these 4. So in broad terms, if you want to treat oxygen, you do it with FiO2 and PEEP. And if you want to treat PCO2, you have to do it by increasing the minute ventilation, which is a direct product of both tidal volume and respiratory rate. So if you're going to remember something of the 20 slides we have today, just remembering this is a lot, because I see all the time that someone is deciding, and what they do is that they increase the tidal volume. That has no real effect whatsoever on the oxygen. You have to understand that if what you want to do is increase oxygen, you have to do it through increasing FiO2 and PEEP. In that same note, for example, if you have a BiPAP and you want to increase the PEEP, what parameter would you increase? It would have to be your EPAP, right? Because EPAP is the same thing that PEEP. Whereas if in your BiPAP you want to increase your tidal volume, which parameter would you increase? It would have to be the IPAP, because the inspiratory one. Now, FiO2 is very straightforward. It's the fraction of inspired air, meaning just how much oxygen you're giving someone. In general, when someone is unstable, you just max your FiO2 to 100 and you can win it down later. But whenever you're going to have someone that is going to be connected to some sort of ventilation or oxygen support for a long period of time, less is more. So you try to win down the oxygen to whatever is the most acceptable SAT that you can get. And remember that we want our oxygen saturations between 90 to 94. One huge pet peeve of all the pulmonologists is that we hate seeing SATs of 100. Because when we see SATs of 100 all the time, it just means someone is not doing their job and is giving their patient more oxygen than what they need. The next one is tidal volume. Tidal volume is pretty much the volume of breath delivered. Now, depending on the mode of ventilation, either volume control or pressure control, you're going to set the tidal volume either by setting a volume or setting a pressure. How do we calculate the tidal volume? And this is something you have to know by heart and you really have to memorize. And we do this based on the ideal body weight. What is ideal body weight? So the ideal body weight is the body weight calculated based on your height. So for example, I'm 6'1". So even if I gain and I weigh 200 pounds, so even if I gain 300 pounds extra and I'm like now morbidly obese, weighing 500 pounds, my lungs are still the same size. So never, ever use the real body weight or the measured body weight to calculate tidal volume, because the size of all the viscera in the body are independent of the real body weight. It has to be with the ideal body weight. Now, the next question you're going to ask me is, where can I get the ideal body weight? Luckily, Epic always automatically calculates the ideal body weight and put it in a column on the left side. But if you cannot see that for whatever reason, just go to MDCalc, type ideal body weight, and you're going to be able to calculate it. And you want the tidal volume to be between 6 to 8 cc kilograms. Why not more? Because the more tidal volume you start giving, the more volutrauma you can do, and you can start popping the lungs and causing pneumothoraxes or pneumomediastinums. So volumes above 8 cc kilogram is not something we ever do. Respiratory rate is very easy. It's how fast the patient is breathing. Remember that if someone is extremely tachypnic on a ventilator, eventually they start breath stacking, meaning they start stacking breath after breath after breath, and volume starts accumulating, which leads to auto PEEP, which we'll talk next. Now, what is PEEP? PEEP is positive end expiratory pressure, and this one is something very important for that all of you need to understand. So PEEP is nothing more than the amount of air that you and pressure you leave at the end of exhalation. So the more PEEP we give, the more we start to recruit the alveoli that are closed. So let me show you a video to get an idea of what PEEP is. This is a video that if you spend enough time in our hospital, you're going to see more than once. So these are a pair of rabbit lungs. And what you're going to see is that during different times, they're going to start giving more PEEP over and over. And the more PEEP starts to be given, you're seeing that how the lungs and the alveoli start to expand, and you start to recruit areas of the lung that were not participating in ventilation before. The interesting thing is going to be that once they reach the maximum PEEP, they're going to start to deflate the PEEP and little by little go down on the pressure. What you're going to see is that now the lungs that you have in the end are recruited lungs because all of those alveoli are now open. Take into account that PEEP and tidal volume have nothing to do with each other. Just because you go up on your PEEP doesn't mean you're giving more volume to the patient. What you're achieving by giving more PEEP to the ventilator is just opening up more areas of the lung. Now, sorry for talking so much about physiology, but this is an important concept that we always try to preach as much as possible because we all love PEEP whenever we're doing mechanical ventilation, particularly in ARDS. But the reason for that is that the more PEEP you provide to a lung, the compliance of the lung starts to improve. And why is that important? Because if you have a very low compliance, in order to achieve your desired tidal volume, you have to utilize very high pressures, right? Because the relationship between pressure and volume is directly proportional. For more volume, you need more pressure. But if your compliance starts to improve, you have to use less pressure to achieve a same amount of volume you had before. So the more PEEP we start to provide to our patients, the more parts of the lung we recruit, and as an end result, the compliance improves. So take into account that that's why for ARDS patients, we're always using very high PEEP to FiO2 ratios, because we know that the more PEEP we give to these patients, the more we're going to be able to recruit and ventilate these patients better. Now, we're going to talk very quickly about modes of ventilation because I'm starting to run out of time, but the big brush that I want you to understand of mode of ventilation is that there are two broad types of mode. One, which is control mandatory ventilation, and the other one, which is assisted or support ventilation. So whenever you're doing control mandatory ventilation, the difference is that the ventilator is doing all of the work and is micromanaging every single part of the respiratory cycle. So you are not really allowing the patient to do much besides deciding when to trigger the ventilator. Everything else is done by the ventilator. Whereas with assisted or support ventilation, the ventilator is doing part of the work, it's just a partial part. And you're allowing the patient to do more work by controlling not only more parts of the respiratory cycle, but also allowing having them more control of the tidal volume. In general, we use all the time control mandatory ventilation, meaning pressure control, volume control, or PRVC. And usually we only use pressure support or volume support whenever we are trying to either do a breathing trial to see if they can be extubated, or when we're doing kind of like physical therapy for the lungs, or people that we expect them to be difficult to wean from the ventilator. The main difference between pressure and volume control, just so you guys have a good idea, is how do we calculate the tidal volume? So for pressure control, what we do is that we set up a pressure, whereas for volume, we set up a volume. And I'll give you more examples of that later. Now, another thing that all of you need to be very comfortable with, and I really encourage you to talk with your residents, fellows, and attending when you're in the ICU to go over ventilators. But what are the parts of the screen of the ventilator? And easy way to understand this is that whatever is on the x-axis is what you as a provider are controlling. So you are deciding what to do with the ventilator with whatever is on the x-axis. Whatever is on the y-axis is what the ventilator and the patient are doing together. So for example, you can set a rate of 15 here, but if the patient wants to breathe at a rate of 30, the patient is going to breathe at a rate of 30. And just because you go down from 15 to 20 doesn't mean the patient is going to slow down its breathing. You can set a tidal volume of 400 here, but if the patient is, having increased work of breathing and breathing very deeply, the patient can be breathing at higher tidal volumes. So make a huge difference that just because you're setting something on the ventilator doesn't mean the patient is doing that. And that's why it's important to look at the numbers on the right, because those are the ones that tell you what the patient is actually doing. Now, there are three curves or scalars on the monitor of the ventilator. The yellow one is the pressure, and you see how it correlates with the pressure numbers on the right. The flow is the green one, which correlates to rate and FiO2. And the blue one is the volume, which correlates with the minute ventilation and the tidal volumes here on the right. So if you ever forget which is which, because you have a horrible memory as mine, just look at the variables here, and they're going to tell you the answer. Centimeters of water, pressure. Volume over time, flow. Volume, volume. So even if you don't remember what is what, just by reading the variables, you're going to be able to like figure it out. Now, one of the things that, you know, health staff always asks for help is how do we deal with common types of alarms? And alarms is something that always scares all the health staff because they just see the ventilator is alarming and they don't know what to do besides asking for help, which already is a good answer for that. The worst thing that you can do when a ventilator is alarming is just silence the ventilator and walk away, because you can be causing harm by doing that. Now, the two most common types of alarms on the ventilator that I want all of you to be very comfortable with is the combination of low volume, high pressure, and the combination of low volume, low pressure. So whenever there's a high pressure alarm on the ventilator, is one of the most important alarms you can see, because that means that something in the system is being obstructed. Either the patient is biting, the tube is kinked somewhere, the patient is coughing, or for some reason there was a huge sudden change in the compliance of the system, and now the ventilator is requiring more pressure. Usually the way you troubleshoot high pressure alarms is to find, is there an obstruction somewhere along the system? Is the patient biting? Suction the tube just to make sure there are no secretions. And after you did all of that, the pressures are still high, then you can ask for help to figure out what is the next step. In a similar manner, low pressure can give you low volumes, but for completely different reasons. Low pressure just means leak, or disconnection. So if you have low pressures alarms, you have to think that there's either a cough leak, the ventilator got disconnected from the endotracheal tube, one of the tubes somewhere got disconnected for whatever reason, and you just have to figure out where is the disconnection. You're never going to see a low pressure alarm for something other than a disconnection or a leak. So that has to be your focus. Apnea alarms, you're only going to see them on support modes of ventilation, meaning if you have, for example, a patient on an SVT and the patient still has some fentanyl running on his bloodstream, then you're going to start getting apnea alarms because the patient is not breathing. And the solution for that is switching the patient back to a controlled mode of ventilation. For asynchrony, unfortunately, there are no alarms. You're never going to get an alarm that tells asynchrony. But asynchrony, what you're going to start looking is that the curves of the ventilator no longer look as pretty as these ones, but they're very irregular. The patient is double triggering for some reason. The ventilator is doing one action, the patient is doing another one, and that's the synchrony. And in general, the answer for asynchrony, instead of trying to figure out, is escalate the issue immediately. You feel that there's something with the ventilator that doesn't make sense, always ask for help. One of the things that it's good for all of you guys to also have an idea is that they can be an intrinsic, occult, or auto PEEP, meaning that the PEEP that we provide to the patients, the good PEEP that we do here, you know, this is what we call extrinsic PEEP. That's PEEP we are giving to the patients. But unfortunately, for many reasons, most commonly in patients with obstructive airway disease, such as asthma or COPD, or patients that are extremely tachypneic on the ventilator, what happens is that they start retaining air inside of the lungs. So because of that retention of air inside of the lungs, they start creating their own auto PEEP, and that's increasing even further their intrathoracic pressure. So all the bad hemodynamic consequences we talked about at first starts happening because of auto PEEP. And I've had so far in my fellowship 2 cases where they call me emergently to a room of a patient that is intubated with COPD or asthma, and everyone is freaking out that the patient is more hypotensive, and they think the patient has a pneumothorax or the patient is in worse shock. And the answer is always the patient is auto-PIPing. And if you look at the respiratory rate, and if you look at the flow curve, you can see clearly how the patients are breath stacking the air. So an easy solution for this is always to disconnect the patient from the ventilator, allow the gas to exit the lungs, and then reconnect the ventilator again. And you can fix the hypotension of that patient because you were causing an obstructive shock by having auto-PIP on that patient. Okay, so before we move to cases, any questions?
Hi, Bertin. Yeah, I have a question. When you mean, what do you mean about like disconnecting the patient is just in what way? Like removing the...
So you don't remove the endotracheal tube. What you remove is the connection of the ventilator to the endotracheal tube. So you allow the positive pressure to create a gradient with the atmosphere and leaves the lungs.
And how long would that usually take?
Usually, unfortunately, it takes almost a minute for it completely to happen. So it's not a good maneuver to do when the patient is severely hypoxic in this setting. And it's always a maneuver that you have to do with some supervision. But you're gonna see it at least once during your residency that many of these asthma COPD patients, we end up like literally doing kind of like a lot of pressure on their thoracic cavity to allow the air to be exhaled. And this happens because the vent was not adequately set up or the patient was not adequately sedated for the level of airway disease that they had. And it happens every single time when there's an asthmatic. Sometimes for an asthmatic, a rate of 16 is too much. So these asthmatics are gonna often require even up to rates of 6 to 8 breaths per minute to actually be able to breathe out all of the air.
Thank you.
Okay, let's move on with some cases. So the way we're gonna do it is that before I start each case, I'm gonna trust one of your chiefs and allows a couple of persons, residents, interns to offer themselves to try to resolve the case in public with everyone here. And then we're gonna go that case by case by case. I have 4 cases prepared. If there's an awkward amount of silence, then I'll just start calling a couple of names of people I know I've worked with. Is that okay, Sananda?
We'll allow 6 seconds of awkward silence before I call someone.
Yes, more than 6 seconds of awkward silence just starts to get too awkward.
You guys are great.
Okay, so case 1. Who wants to go? I need 2 persons.
So I can do it, but I can't see your. I don't think you're on the right slide.
I know. I don't want to give you the answer yet.
Oh, okay.
I can join as well.
So it's Juan and who else?
Bruno.
And Bruno.
Okay, awesome.
Thank you.
So case number 1, this is the easier one because you volunteered on participating. So the resident and the fellow are gowned up doing an IJ that has been taking them half an hour, which is kind of embarrassing. The patient is completely sedated and paralyzed, and they call you to help because the ventilator is alarming and they cannot see the screen because they had the brilliant idea of making the ventilator face the other way when they're doing a procedure. You enter the room and what you see is that the patient is desatting all the way to the 70s, 80s, and the ventilator is alarming low volume. What do you do besides hitting the silence button?
Check if there's any disconnection within the system.
So, correct. Yes. And that's a very simple way of troubleshooting the issue with the ventilator, right? Such a simple problem. If the ventilator is giving you a low volume, low pressure alarm, all you have to do is find the disconnection. And if someone is doing, for example, an IJ, the face of the patient is going to be facing laterally, and it happens every time that the ventilator gets disconnected. That being said, whenever you have a disconnection from the ventilator, everyone always fixates on the endotracheal tube, but trying to take into account that the ventilator has multiple parts, and the ventilator circuit can have multiple disconnections all the way from the direct endotracheal tube that goes to the main circuit, the inhalatory port, the exhalatory port, the humidifier, the filters, all of that can have these connections everywhere along the route. So whenever you're seeing that, don't fixate, oh, the ventilator is connected to the endotracheal tube, everything's okay. You got to check the entire ventilator circuit to make sure that there's no leak as well. Okay, let's do case number 2. Who's offering for the next one? Bruno, you can help with the next one since you already offered with the first.
And then Tom, who was about to unmute himself. There you go.
I'll help too. Yep.
Okay, perfect. So the case number 2, we have a 60-year-old male with AFib and AC admitted with upper GI bleed and intubated for airway protection due to hematemesis. The patient was admitted to the MICU status post-embolization. Because it was late at night, the patient went for embolization and not endoscopy. The vital signs are normal, but the patient is requiring a phenylephrine drip. And these are the ABG that you get directly as soon as the patient gets to the unit. The pH is 7.19, the PCO2 is 50, the bicarb is 10, the lactate is 8. The height is 120 kilograms, and sorry, the weight is 120 kilograms, and the height is 180 centimeters. So let's do an exercise. Can you see my screen here?
Yep.
Yes.
Are you seeing the ventilator?
No, we're seeing case 2.
No.
Okay. Do you see the vent now?
Yes.
Now we see it.
Awesome. Okay, guys. So this is literally what you're seeing on the ventilator when the patient gets to the unit. And these are the settings that the patient have. And try to think of what the patient had. The patient pretty much had a severe metabolic acidosis with a PCO2 of 40 and a very low pH. So given that these are the settings of the ventilator, take your time, think about it, and what changes do you want to do?
Well, so in a patient who has a low pH and a metabolic acidosis, normally the body would try and compensate by increasing ventilation to blow off CO2. So essentially, we want to try to mimic that with the ventilator. So there would be 2 ways to do that: either increasing the tidal volume or increasing the respiratory rate. I think we don't know the person's ideal body weight, so without knowing that, I don't know if they're closer to this between the 6 and the 8. cc's. Sorry.
Why do you guys have empty calc on your cell phone? So just as an exercise, find the empty calc on your cell phone and try to calculate the ideal body weight. That way you know how to do it for next time that you're in the ICU with a ventilated patient.
It's 165 pounds.
Okay, so how much would that be on kilograms? Pardon my the math deficiency.
75.
How much?
75.
75. Okay, so 75. Now you have 75 kilograms of ideal body weight. What do you do with that?
I can multiply it for 6.
So good. Let's start with that. 75 times 6.
450.
450. So the minimal tidal volume that this patient should be having is not 300, clearly. So we're going to increase that to 450. And we set up our 450 here. Let's do 457. Trying not to be as OCD as I'm usually am. What about the rate? Should we leave it on a rate of 12 or should we do a change on the rate as well?
We can try to do the change in the tidal volume first and then check about the rate.
So take into account that if this patient was not intubated and was breathing physiologically and was not deeply sedated, how would you expect the rate of the patient to be?
To be high, to try to blow out CO2 as much as possible.
Correct. So you have to try to emulate a little bit that physiology, that normal physiology. And the moment to be aggressive is the moment the patient is sick. And just if you look at that gas, would you call a screen on that patient? Yes. So equally, we have to be equally aggressive at trying to fix that gas. We cannot wait for the patient to get worse. We have to try to get that patient better. So you would ask me, how much would I give of rate? And I'm gonna give you a very empiric answer. But the thought process that I want you to have is that if you had a patient with a lactate of 8 and a pH of 7.2 on the floor, and you went to examine the patient, which rate would you expect to see in a patient? Do you expect them to be breathing at 15 breaths per minute?
Mid-20s, high
Mid-
30s, like to 30 maybe?
Yeah, 30 even. So the question that you have to do is, can the patient tolerate a rate of 30? And let's see. And we're starting to see that here on the flow curve, right? Now, one of the things that I want you to pay attention is that the patient here is tolerating a rate of 30, but do you see that the exhalatory curve is not fully returning to 0? Do all of you can see that here? It's a very small detail, but you can clearly see it here. And when you start to see that, that means breath stacking. So that means that the airways of the patient are not tolerating that extremely fast rate. So you have to allow the exhalatory phase to be a little bit longer. And an easy way to see that is in this part here. So what is the IE ratio I'm seeing here? 1.5 to 1. What is the normal inspiratory to exhalatory ratio in all the humans around, like in a normal person?
2 to 3.
Is 1 to 2. So the exhalatory time we have needs to be at least twice the inspiratory time that we have. So you have two ways to fix this issue. One, you can decrease the rate and go down to, for example, 22. And let's see what that does on the IE ratio. You see, it's better, but it's not fully to the 1-2 that we usually would want. Or the other option is your inspiratory time. You can decrease it. And let's do 0.8, and now it's better. Does that make sense to you guys? It's much better when you see it in real time, because you can actually understand that everything is connected. And it's very logic for everyone that is as bad at exercising as myself. Just try to picture going yourself up doing any type of exercise and breathing very fast, and what you're gonna see is that your inspiratory time is also not as long as you have it usually. Your breathing is shorter. So you have to emulate that as well with the ventilator. And the more we go down on our inspiratory time, the more it will allow you to have a faster respiratory rate. And you're gonna see that the faster your rate is and the faster your tidal volume is, your minute ventilation here also starts to go up. And if you have a patient in who you want to really help them clear CO2, that minute ventilation has to be greater than 8. It cannot be less than 8. It has to be greater than 8. You have to push that. Okay. Any other changes you would like to do to the vent? We took care of the CO2. The last question I would have to do is, do you want to leave the FiO2 at 100? Does the patient need that? What do you want to do?
Lower it and then watch the SpO2.
Correct. So, we can go all the way to this patient is just coming with a GI bleed, has no ARDS, no pneumonia, not on oxygen at home. You can go down to 40. And when you go down to 40, you're going to see that, the SAT is now 94%. So that's what the patient needs. So you don't have to keep people at 100 all the time. Sometimes, for example, the ED does that because nobody's watching the patient. Sometimes the patient not connected to a monitor, they don't have enough staff to see it. So it's safer to keep them on the 100%. But if the patient is on the unit with a bunch of staff taking care of the patient, you have to start doing part of the weaning process. Okay, any questions so far before I move to the next case? Awesome. Okay. Who is up next?
I can try.
Okay, Nadim, who else?
I'll volunteer as tribute too.
Awesome, I love it. Okay, now let me make this patient very sick for you guys. Okay. Okay. Case number 3. You have a 75-year-old with history of COPD and bronchiectasis admitted with acute hypoxic respiratory failure and bacterial multifocal pneumonia, intubated in the ICU. It's the middle of the night. You are completely, totally, utterly alone in the unit because the resident went to get a coffee all the way in Clark 5 and the attending is dealing with an RRT in the ED with the AC. So there's nobody else besides you, the nurses, and that's it. One of the nurses calls you very quickly because the patient is deciding and the vent is alarming. You rush at the bedside of the patient, and what you see is this. The ventilator is alarming. It's telling you that the pressures are very high. And the patient, even though is set up for a volume of 450, is not really getting the volume the patient should be doing. What do you do?
I think we said like when the pressure is high, you want to first look for any type of obstruction. Is the patient biting on the tube? Could there be secretions that we need to suction and see if that improves? Versus like something, changing acutely with the compliance of the lung, which we would assess after ruling out.
You have your patient in front of you. What do you want to do with the patient? The patient is deciding, the oxygen is dropping down. Now the patient is 75. Where do you want to start your search for an obstruction?
Start by suctioning the tube. Make sure he's not biting anything.
Okay, good. So the patient is not biting the tube. The patient is very sedated. You put in the suction catheter. And when you start suctioning, you realize 2 things. One, some secretions are coming out, but the suction tube is, being stuck almost halfway through the endotracheal tube. What does that make you think of?
Maybe like a mucus plug or.
Darren?
You said that as you're suctioning that it's stuck halfway through the endotracheal tube.
Yeah, it's not going through like fully as it should.
That means that there's some sort of physical obstruction that's there. The question
Correct.
is, what is that physical obstruction? I would assume is it the endotracheal tube? Well, it's going down the tube and it's stuck. So what else could be down there besides endotracheal tube?
In the meantime that we're talking all about is the SATs are dropping more. It's 70% now. Is there anything you want to do with the actual ventilator to give more oxygen to the patient?
Yeah,
well, the person, yeah, so because it's an oxygenation issue, right? It's not really a ventilation issue and he's not getting enough oxygen in general. We have room to go up on his either his PEEP or his FiO2. So
which one? Which one?
In this case,
so which one do you want to do?
FiO2 first.
Okay. How much?
Maybe let's go up to, well, I would bump it up to 100 just because he's sitting at like 70%.
Good. And that's exactly what I needed to hear from you guys, because I've seen this on real time so many times that a patient is deciding and someone doesn't want to be aggressive and they go like from 40 to 45 or 50 because, too much oxygen is bad. My response to that is also like hypoxia is not good for you. So whenever you have a patient crashing in front of you and the patient is deciding, never negotiate with oxygen, just crank up the oxygen. Same thing if you are on the floor and a patient is deciding, you don't start, with a nasal cannula going little by little to 4 liters. You grab a non-rebreather and you slap it on the patient. Same principle. Whenever someone is deciding and crashing in front of you, don't negotiate with oxygen, slap it all the way to the maximum. So now you're giving 100% and the patient sat is going back to 93%. Now the patient is setting better, the peak pressures are still high, but now your resident and your attending are here. They grab the ambu bag, they start to bag the patient, and they realize that when they're bagging the patient, there's a lot of resistance on the endotracheal tube. And as you guys were suspecting, the patient had an endotracheal tube obstruction. So once the attending gets there, they decided to extubate the patient and exchange the tube. And this is what they see, a completely blocked endotracheal tube, which, believe it or not, you would think that this is a rare thing that never happens, but it happens quite often, particularly with patients that have a lot of respiratory secretions and have a lot of that, very thick, copious secretions. The endotracheal tube gets obstructed very easily. Try to think about what is the diameter of an endotracheal tube. It's not that much. And you start to sediment mucus and pus over the course of a week, eventually that's going to get clogged. And one of the things that we forget is that we think that the clogging process happens, suddenly. It's little by little until that tube is completely clogged. The teaching point you guys have to get from this case is 2 things. 1, high pressure alarm, you think of obstruction. And 2, whenever a patient is deciding, don't negotiate with the oxygen, just straight up increase the oxygen as much as possible, go to the highest level of oxygen, and then you can start thinking about what is going on. But the most important thing is to immediately deal with the abnormal vital sign you have in front of you. Same thing, you're in the floor. The nurses calls you, hey, come to the bedside, this patient is deciding. The patient is on a nasal cannula. You can increase the oxygen on the nasal cannula, but you need to start already having your plan B. Go get your non-rebreather and have it at bedside to give it to the patient immediately. But you cannot be going little by little when a patient is unstable. If a patient is hypotensive, you're not going to be thinking, should I do NS or should I do LR? Just grab whatever fluid you have and start giving it to the patient. Deal with the emergency acutely and try to fix the vital sign as soon as possible. Sananda, do you have time for one more case or are we done?
Of course we do. Only because it's you, Bertin.
Oh my God, I feel like so good right now. Okay, let's do one more case.
Sorry, quick question.
Yeah.
Something like an endotracheal tube obstruction. So you said you can try to go in with the suction and see if there's something blocking. Would something like this show up on an X-ray, or you have to actually check? No, okay.
It doesn't show up on the X-ray. The only way that you can figure out if an endotracheal tube is obstructed is you physically have to insert the inline suction into the endotracheal tube. And I encourage you, all of you guys, when you're in the MICU, learn to use the inline suctions. To me, that is like bread and butter ICU, because you have to get used to the feeling of how deep a suction can go. And that's going to teach you whether this is normal or abnormal. But if you never use an inline suction, if you have no experience whatsoever using one, you are going to have no idea knowing is this deep enough, is this too shallow, is normal, is it abnormal? So you have to do these things very regularly to get that feeling and that muscle memory of how many things are done. That's one of the very cool things that critical care gives you, is like muscle memory on many things that are part of the medical care of the patient. Okay, who wants to do the new case?
Does this mean I get to call on someone?
Yes, this is an awkward amount of silence.
Yeah, I think Sherelle would be up for the challenge. Sherelle Sadoud. Yeah, there you go.
Yeah, sure.
Does anyone want to give her a hand, form a team with Sherelle?
I can help her out.
Thank you, Tyler.
Awesome, Tyler. Okay, Tyler and Cheryl, let's start. So case number 4. This is bread and butter MICU from 2020 to now. New admission to the MICU straight from the ED. It's a 55-year-old male with type 2 diabetes coming with COVID, pneumonia, and ARDS. Initially with mild ARDS, but the patient had been boarding almost 12 hours in the ED. The X-ray is how it looks in the right, which is pretty much looking horrible. On the right side, the central line is already in, so you don't have to do that procedure. The SAT is 88 on an FiO2 of 100 and a PEEP of 5. The last gas that you got from the patient, once the patient got immediately to the unit, was a pH of 7.1, a PCO2 of 60, a PaO2 of 49, and a bicarb of 15. Now let's take a look at the vent. And this is what the vent is showing you. This is literally how the patient came from the ED. So what changes do you want to do and why? And take a second. This is not a patient that is crashing. The patient is setting 86, which, believe it or not, is not that bad. The gas showing you very bad respiratory acidosis, some hypoxemia. What changes do you want to do to the vent? And it's very important that not only tell me what you want to do, but why.
So I would say we can try to modify the PEEP because normally, like in ARDS patients, we try to like increase the PEEP to it could be 10, 8.
Okay, so one of the things you're bringing is a very good point, is that whenever we have someone with ARDS picture, we have to give them PEEP, right? Because how would you, Tyler, expect the compliance of that ARDS lung?
Poor.
Horrible, extremely low. So we need to help that compliance. And how are we going to do it? With PEEP. So, Cheryl, you want, how much PEEP do you want?
I would say 10.
Okay, let's start with 10. What do you expect will happen to the blood pressure as we start to go up on the PEEP?
It can go down because we're increasing the pressure.
Correct, yes. And I see this question very often. You know, I'm doing changes on the vent, I go up on the PEEP, and the pressure starts to drop. And, you know, someone also asked me, hey, is like the patient more septic now? Why is the blood pressure dropping? Because you're going up on the PEEP, and it's happening because you're giving more positive pressure. It's an expected change. And that's why usually when you have a patient that is coming to the unit hypotensive and hypoxic, you have to deal with the blood pressure at the same time, right? You cannot just do a lot of PEEP on that hypoxic hypotensive patient, because if you do that, what's going to happen is that the blood pressure will crash because of the PEEP you're giving. So it's going to make the shock worse. Okay, now my ventilator is failing. Just ignore the curves. What changes do you want to do on the tidal volume and the rate?
So I don't remember how was his height, so we can calculate the tidal volume in this case.
Let's do that. So it's a male, 60, and his height is 165 centimeters.
So it's going to be 61 kilograms.
Okay.
And in ARDS, we should try to go like down on the tidal volume, right? It should be like 6.
Correct. So how much do you want to do? Give me the ml amount.
We can go like 365.
360. Okay.
Mm-hmm.
So we go down and we do 360 here. Okay, 360. What do you want to do with the rate?
I would like lower the rate down probably. Well, this patient has acidosis, but
Correct.
so we can, in my case, I would go like down to 25, probably 26 on the rate because we're trying like to breathe him
Correct.
out.
And that's very important. Whenever you have these patients that have very bad acidosis with ARDS, as you start to go down on the tidal volume, because you're trying to protect that lung, you have to go up on the rate. Because if you only go down on the tidal volume, what do you expect is going to happen to the CO2?
It's gonna go up.
Correct. You're going down on a tidal volume, the CO2 will go up as a response. So you have to reflectively increase the rate. One of the fascinating things about lungs with ARDS is that because they have such a low compliance, their elasticity is very high. So whenever you have a lung with stiff lung with ARDS, it's going to take you a lot of pressure to inflate it. But because it's so stiff, the elasticity being very high, the lung recalls to the original position very quickly. So because of that very high elasticity, those patients very easily tolerate high rates. So in these patients, you can no problem whatsoever do a rate of 30. Most of the patients will tolerate it and they're going to be fine with that. So you go to that tidal volume of 60 kilograms, you go to that rate of 30 breaths per minute. You go up on that PEEP to 10, and you're going to keep that FiO2 at 100, right? Because you cannot start titrating an FiO2 when the patient is still deciding on the ventilator. So you have to give that time to the PEEP to work before you start changing your FiO2. One advice I'll give you, all of you, in case you've never seen this, is to get familiar with the ArtsNet tables, in case you've never seen them before. These are in Mount Sinai West, are in all the computers and all the ventilators, and I'm sure you've seen them over and over. And all of these tables have the objective of trying to give you an idea of what should be the PEEP that the patient have if their FiO2 is very high. Most of the times here in our ICUs, we do a lower PEEP, higher FiO2 strategy. So for example, if you have a patient with ARDS that is requiring an FiO2 of 100, your PEEP should be able to go all the way to 18 to 24. That's how high your PEEP should be heading towards to. That being said, you're not gonna go from 5 to 18, right? You have to do incremental changes to make sure the hemodynamics of the patient are able to tolerate them. But if you have that patient with an FiO2 of 100 and the patient is now sitting, on the low 90s, this table, what's trying to give you is the idea that the patient's PEEP can still go up. You should still be able to give more PEEP to the patient without being worried that it's too much. So whenever in your head it doesn't make sense, the FiO2 to PEEP relationship, look at these tables. They're fantastic and they're going to give you an idea of what you should be doing. Okay, guys. So that was my last case, and I'm really happy that my fake ventilator failed on my last case. That's it. We have 3 more minutes. That way you can get a break. What questions do you have that I can answer for you?